Let's talk about respiratory distress. I talked about two key areas for pediatrics that we need to focus on, and respiratory distress is one thing that I just want to touch on today. When you think about the pediatric population, why are they at risk for upper respiratory issues? Well, one is the upper airway is shorter and it's more narrow. So if you think about an adult's airway, so our airway maybe about that big, maybe a little bit smaller. Maybe their airway might be that small, so maybe 4 or 5 meters in diameter. Now, if we think about if we have any type of upper respiratory inflammation or any kind of tightening, pathological tightening of that area, with 1 inch, it makes a significant difference in a pediatric airway versus 1 inch of, actually, I shouldn't say 1 inch, maybe about 5 millimeters of swelling, mucus, or inflammation. 5 millimeters of swelling and mucus information on an adult airway is much easier to support than 5 millimeters of inflammation or irritation on a pediatric airway. Okay, so just think about the sheer size of what it is. Newborns breathe through their nose. That's what they do. So very important is keeping their nares patent. If, for instance, if someone has RSV and they have, you have a question on your exam that maybe you have a patient, you have a 3-month-old or something with RSV, and they are not, they're not taking their feeds. What are some things or interventions that you can do? Always make sure that their airway is clear in order for them to eat. That's just one of the supportive or nursing interventions you do. Suction their nares prior to feeding. And that's because we need to think about their airway and that they always breathe through their nose. Keep that in mind. So the larynx is more flexible in the pediatrics than it is in adults. And then, so if it's more flexible and more loose, then it can spasm and it can clamp down much more tighter than it can for adults. Their intercostal muscles are not fully developed. So they have not flail chest, but they cannot coordinate necessarily their breathing. So the retractions, you'll see them, they'll be definitely more distressed when it comes to retractions in general. There's not enough space or alveoli in their lungs to absorb for oxygen molecules to attach to. So there's fewer alveoli. So therefore, if there's fewer locations for the oxygen molecule to attach to, then therefore it doesn't carry enough oxygen throughout the body. So that's one other reason why respiratory distress is very concerning in the pediatric population. The other thing is that, so you have this narrow airway, then you have these huge tonsils that can pretty much block the airway. So that's why tonsillectomies and tonsillitis is more of a concern in the pediatric population than the adult population. Okay, we're older, we have these huge tonsils, however, we have the infrastructure to support it. But for infants, it's all a very small space. So that's why young children will have their tonsils removed more than adults. Okay. Decreased immune function between 3 months to 5 months. It's just really immature immune system as it's building and as it's growing. So that's something to think about. That's why that is the range. Know what your immunization schedule is and understand when immunizations are given. And that's the area, that's the reason why, is because their immune function is decreased. So they need to be immunized during that time. And so understanding what your immunization schedule is important and will be tested on the infants. So early signs. So